Make this an official start. Hi, everybody. I'm Ken. I help organize the regular North City Tech Meetup group. We're a fairly informal group of people that meet once a month under normal circumstances in the North End, usually at one of the North End libraries. The idea being to have a tech-oriented meetup for people who don't live or work downtown or on the east side. And we have a variety of different topics, usually tech-related, from things concerning startups to computer programming to biology and kind of you name it. So next month, again on Zoom, we'll have, the topic will be Financials for Startups by Andrew Klein, who is an accountant who works with startups. So this will be of interest to people who are considering a startup or have an early stage startup and want to know how to plan and manage your financials for that. Then after that, that's May 4th, and on June 1st, we're having Get Plugged In with Electric Cars by Mark Schiller. This is a repeat of the one in February, because that's just when the virus hit and we only had 3 people were able to show up at that. So we're going to repeat that one again. That subject near and dear to my heart, since we have one electric car now, and I have no intention of ever buying another gas car again. But today, we're here to learn about COVID-19, and we have Dr. Marguerite nope, forget it.
I'll help you out. Pappaioanou.
Pappaioanou, I tried. Yeah. I'm thrilled that she was able to join us. King County Health Department has a speakers bureau, and they very kindly made Marguerite available. She is semi-retired. As you can see from her bio that went out, she has quite the extensive work history. I'm also thrilled because we are both Cal Aggies. We even overlapped at UC Davis, although she was in grad school in the vets department at the time when I was a lowly undergrad. Anyway, she is here to do a presentation about the epidemiology of COVID-19. The plan is for her to do a presentation and then have several, we have 2 or 3 COVID-19 survivors here with us who will talk after that, and then we'll take questions. If you have questions while we're going on, you can type them into the chat room. But I'm afraid if we open up the mics, it'll kind of be a madhouse. And Marguerite can determine how she wants to manage the questions, but we'll probably take them at the end, just in order to keep things moving. Again, we've never done this online meetup before, so we'll see how it goes. And at this point, I'm going to turn it over to Marguerite.
Thank you. And let's see how this goes here.
There we go. And you guys, you can enter speaker view and you will see see her presentation. You don't have to see all. You can decide how much of the other things you want to see.
Okay. Well, it's a real pleasure to be here this evening with you all. And I have a couple of things I would like to just say right at the beginning. First of all, I would really like to thank Dr. Susan Buskin, who's on the call with us. She's an epidemiologist at Seattle King County Public Health, working in HIV/AIDS and sexually transmitted diseases surveillance. And she and I, as I started to pull together this material, I collaborated very closely with her and her group, and we were going back and forth and trying to improve what we had. So it was a very nice collaboration, and I want to thank Susan for that. Secondly, this is just this presentation is current as of this evening. And as I will comment, especially at the end, this is information that is changing daily and sometimes even hourly. And so what I'm going to share this evening may look very different even a week from now. So, but we're sharing what we know as of April, this past weekend, April 4th, 5th, and 6th. Oh, this is interesting. Oh, okay. All right, so as we come together this evening, we are here amidst what is the coronavirus pandemic, or COVID-19, and I will mention that a little bit in a few minutes more. And as we come together, this is this graphic was taken from the Johns Hopkins University in Medicine Coronavirus Resource Center. Anybody can log in and pull this map up, and it gives constant updates on what's happening globally, by country, and by within the US by state, on where we are with the spread of the virus and cases and deaths being reported. Although very nice, they also, see if this will work, they also keep indicating total recovered too, that we know of. So that's very nice. So here you can see that as of last evening, there were 1.273 million people around the world that had been reported with the disease, and 69,419 deaths. The World Health Organization website, which each of these groups keep track of cases and deaths at different time points during a day, so the numbers can vary. But if you were to go to WHO's website, they would, their figure there was 1.136 million case patients and almost 63,000 deaths, and 209 countries. The US, the statistics that I show here are from CDC's website, the Center for Disease Control and Prevention's website that keeps track of US cases. And again, as of last evening, they were reporting 304,826 confirmed cases in the United States, with 7,616 deaths. Looked at a different way, and this is what's called an epi curve. And actually, even by the end of this, and we might even be able to call you all, you know, new epidemiologists, because you're going to learn some epidemiology tonight, and how epidemiologists portray data and how they learn what it is that they learn. So one of the very important tools that they have is called an epi curve, and that is over time, which is on the x-axis, and they have numbers of cases on the y-axis, and these are daily reports. And so you can see that starting from January, which is when this graph first, the data was, they used this as a start for this, for the epi curve, through January and February and March. The cases were few enough, they didn't even show up, given they had to scale this. They didn't use a log scale, they could have, but they didn't. And so to get from 0 up to where we are now, you can see the rise and a very steep slope on the number of cases in the United States between January 12th and April 14th. You can see there, we're starting in mid-March, really, the cases really started to increase. And Washington State, here we are in Seattle, and Washington State also started with only 1 case, but as we can see from this graphic, and this is from the Washington State Health Department. They have their COVID-19 website, so you can actually pull this up, and this is updated. and they show the distribution of cases over the state, but then they also have cases by county down the left here. And I couldn't get all of our counties on this one graphic. So King County is not showing here, or Snohomish, but we can see over here that really the counties with high cases are shown in the darker colors, and that statewide, as of yesterday, there were almost 8,000 cases reported in the state, with 338 deaths. So global to state and local, the numbers are quite sobering. And then also, I'll come back to this a little bit later, but another way to show what's happening in Washington State is this epi curve. So the previous one I showed from CDC, that was US national. And then this is what is happening with reported cases from the date of illness onset. And so cases over here in time across here. They also have a similar graphic for deaths, and I'll be showing that a little bit later. So just so, again, it's percolating along, but then a very steep increase. You do not see these kinds of epi curves for many, many, many diseases. This is very, very unusual and special. So how did we get here? Well, right at the end of December, the World Health Organization office in China reported pneumonia of unknown cause being detected in a big city in China, Wuhan. And that between December 31st and January 3rd, so really only about 4 days, they reported 44 case patients with pneumonia of unknown cause, causal agent not being identified. January 5th to the 11th, the Chinese had identified, isolated, and shared the genome of a brand new coronavirus in people. This virus had never, ever been seen in people in any other previous, in any context throughout the history of humankind. This is brand new. And so also right about that same time, China reported that in the initial outbreak that there were early exposures of some of their cases they had been to the Wuhan city seafood market, which is also a live animal market in China. And for those of you not familiar with Chinese culture and custom, that they like foods that aren't on the usual menu of most Western American diets and menus. Exotic animals are considered delicacies, and so they have live animal markets where those types of animals are sold and can be purchased, and then usually find their way into different foods. So very culturally important. The January 30th, the outbreak was declared a public health emergency of international concern. WHO declared that. And then by February 11th, WHO had formally named the disease with this virus as COVID-19, and the name of the virus is SARS-CoV-2. It's a virus that is similar to the virus that caused SARS, severe adult respiratory syndrome, a severe acute respiratory syndrome that occurred in 2003. But this is a different virus, it's a different disease, but they have some kind of relationship from the past. But the name of this disease is COVID-19, and the virus is called SARS-CoV-2. Of course, people also refer to it as the novel coronavirus or coronavirus in today's environment, but they do have actual formal names. And then on March 11th, the World Health Organization declared COVID-19 a pandemic. And I'll be talking a little bit about those terms shortly, epidemic and pandemic. Continuing on in the United States, January 21st was the first confirmed case in the United States, and of course it happened right here at home. And a man who was aged in his 30s had traveled to Wuhan, had come back, and he was diagnosed with a novel coronavirus. February 26th, another important date, that was the first case of suspected local transmission in the United States. Early on, there was special attention to people who had traveled to China, to Wuhan, or other areas of China that were seeing a lot of cases. But this was a first case where it was a California patient with no history of travel to an outbreak area and no contact with a person diagnosed with the virus. At that time, Oregon, Washington, and New York also were reporting cases of possible community transmission. So when the exposure is through travel, that's a travel-related case. But then when there's community transmission, that means it's spreading locally, and you don't necessarily have to have someone who traveled to an outbreak area. So that started to kick in around February 26th. And then February 29th, the first death in the United States also occurred from King County. Now, this was a different person than the first case. And also around that same time, sadly, we had another first. The first infected healthcare worker was also reported at the end of February. So during March then, and because here we are in early April, basically then this community spread was beginning to occur more frequently and take hold. There were clusters of infections in long-term healthcare facilities and other healthcare facilities and within families and within close contacts of known cases. But basically, the health department was starting to see patients being reported and who had symptoms of COVID-19 with people who had not traveled and who didn't have another explanation for their exposure. Okay, so back a little bit. It is a hypothesis, it has yet to be confirmed, that the very first cases of this disease actually was the result of this SARS-CoV-2 virus jumping from an animal that was being sold in this live animal market in Wuhan, China, into a human. And so some of the early evidence to suggest this link was over, you can see with this graph that in pre-January, that the numbers of linked cases versus not linked to this animal market changed markedly. So this is where it's a hypothesis, and so a lot more study needs to be done. They suspect the reservoir of the virus is a bat, and then the bat could have infected some other animals that are sold in the live market and then infected a person. And of course, in today's world, where you have many, many people living very closely together in cities, and then rapid travel, that we see people traveling very rapidly around the world, it's really not a surprise then that this virus, and we'll talk a little bit later how easily it's transmitted, but it is transmitted fairly easily. It's a contagious virus, found itself in an environment where it could just really take off. And person-to-person transmission then took over from, again, what was thought to be an animal connection at the start, but very quickly it turned into a human health into a human disease. Coronaviruses are a large family of viruses, And they're called what they are for their crown-like spikes on their surface. And you can see the picture in the lower right corner showing those red little crown-like things. So that's where coronavirus is. There are a lot of them. And a lot of them infect a different species: bats, camels, cattle, cats, pigs. Those coronaviruses, it's fairly species specific. So a lot of those coronaviruses do not infect people. However, 7 of all the coronaviruses that we know about, there are 7 that are known to infect humans, including the common cold and some other very benign, almost benign. You know, you can have a terrible cold, but nonetheless not hugely causing severe illness. But there have been 3 that are known to have infected people and been spread from person to person, where there was a beginning where the source was some animal. And again, I've listed SARS-CoV-2, but just a heads up, again, this has yet to be confirmed. SARS was confirmed. It was a bat to some civet cats that were sold in a Chinese market. And MERS actually involves camels in the Middle East. So again, it's a smaller number of these, but we are starting to see more of them. All right, I'm going to mention these terms here that are used a lot. So an epidemic, when you hear someone call an outbreak or a cluster of diseases an epidemic, that really refers to an increase in the number of cases of a disease above what is normally expected in a given population at risk, could be a population in a specific area or some other definition of a special population at risk. And of course, key there is you have to know what's normally expected. So that is where the disease surveillance that is carried out as part of public health, and I'll talk about that a little bit later too. You have to have disease surveillance so you know what the expected is, so that all of a sudden if you see an unusual rise or a number over what's expected, then that would meet the definition for an epidemic. Oftentimes epidemiologists will refer to epidemics as outbreaks, because you can have a very small epidemic. You can have, a disease like this where the expected number is 0, and if you have a single case, that would be an epidemic. So outbreak and epidemic are often, just practically speaking, are used interchangeably. And sometimes outbreak is used over epidemic. It just sounds a little less threatening and a little, not quite at the worries of causing undue fear. So the terms are used interchangeably. Pandemic refers to an epidemic that's spread over several countries or continents, usually affecting a large number of people. And they're often caused by a novel microbial agent, most typically viruses. Sometimes it could be a bacteria such as bubonic plague, but influenza, H1N1 in 2009 spread around the world. That was a pandemic. And now we have this virus and pandemic that we're confronting. Okay, so how does this virus spread? It goes person to person, mostly via droplets, and less often transmission occurs by someone who's infected, who coughs or sneezes. The droplets are they're viable virus that actually are encapsulated in some mucus. And so when somebody coughs or sneezes, those droplets are expressed, but they're somewhat heavy. So after beyond a certain distance, or once they're sneezed or coughed out, they'll start to fall. But when the transmission occurs is if people are very close to one another and somebody is coughing and sneezing these droplets out, and those droplets land on the face of another person, their eyes, their nose, their mouth, and that's that's exactly how a lot of the main route of transmission. However, for those droplets that don't necessarily make it to someone else's face and they can drop onto a surface. And so if somebody else comes along within a particular time frame where there might be viable virus still there, and they touch that surface with their hands, and then they touch their hands to their face, they can also, and they touch their eyes or their nose or their mouth, they can become infected that way. How much that happens is, and there are a lot of unknowns with this. We'll kind of summarize what we know and what we don't know at the end, but how much that type of transmission by a surface happens has not been quantified as of this time. And the main route of transmission is this first bullet there, person to person via droplets. So, and the virus in droplets may survive on surfaces from a few hours to several days. Now, I've got a table with the actual data that I'm not going to go through in detail. We'll post this presentation, so afterwards you can actually look at the data. But this is a very nice graphic showing the main info. That a study was done recently, within the last couple of weeks really, funded by the National Institutes of Health. And they found that a set amount of virus that was placed onto cardboard, copper, cardboard, plastic, and stainless steel, they could find viable virus 4 hours later from copper, 24 hours later from cardboard, plastic 3 days, and stainless steel 3 days. However, the amount of virus that was there at the end of those time periods, the titer of those viruses had dropped substantially. So there was not a great deal of virus that made it through, but nonetheless, it could be detected. And this is the table I'm talking about, and just for time considerations, will not go through it in detail, but you can see, and also I've given the reference there. This is all public access, and so you can Google it and actually get the exact study if you're interested. Clinically. Okay, so if you're infected with if you're infected with the virus, with SARS-CoV-2, typically the main symptoms that people feel, and we're going to hear from several people afterwards who actually lived through this, so they will be sharing a whole lot more on this, but typically the majority of people will have fever, temperature of 100.4 degrees Fahrenheit or more, a cough, oftentimes dry cough, but it can be different types of cough, but typically they'll say dry cough, and shortness of breath. And then other symptoms may occur also, and I've listed the atypical ones, some, that will occur differently in different people, and you'll see a lot of these atypical signs actually come up with a whole lot of different types of diseases. So, but nonetheless, doing careful interviews of people who have become ill with COVID-19, these are the types of clinical signs and symptoms that the virus results in. Other important facts to know: the incubation period for this is 2 to 14 days after the last exposure. That is, incubation period being when you were exposed to when you become ill, when you start experiencing signs and symptoms. Some studies from China have shown it could be as long as 24 days, but the vast majority of infected people start showing signs by day 14. There's an average incubation period of 5 to 6 days. The virus is found, as we've talked about, in large droplets, but it also has been found in stool and in blood. Healthcare-associated transmission is a major mode of infection, especially early in these novel disease situations, and which is awful for them personally, but it also means sometimes they may not be able to stay on the job and continue to work and take care of people. And it also can mean as they go home that they can begin to transmit their infection that they got from a healthcare setting to the community. And so that's it's a way that community spread can start to occur. A very important number on infectious disease agents is what's called the reproductive number, R0. And this is a value that's given for the expected number of transmissions from one infected person to others in a susceptible population. So this reproductive number of 2 to 3 would mean that without any intervention, someone infected with COVID-19 on average would infect an additional 2 to 3 people. So as long as this R0 is above 1, that means the outbreak will continue to grow and more people will become infected. If it drops under 1, that means for every infected person, fewer than another person would become infected, then the outbreak and epidemic will start to come to a close. Recently, transmission has been documented occurring from asymptomatic infected people. That has been confirmed, or early that they transmitted their virus before becoming symptomatic. So this is very concerning and really complicates how to control this. And then, of course, a case fatality rate. That is the number of people dying from a number of infected. So of those, and of the number of infected people, what proportion died? That's what the case fatality rate is. And basically in general, it's around 1 to 3%, but it can be higher depending on age and underlying health conditions, which I'll mention shortly here. Groups at higher risk. So people who are 65 years or older, doesn't matter how healthy we all are. I'm in this group. And just the very fact that we've been blessed to get to 65 years of age or older, it's good, but our immune systems are not as strong as they were when we were younger. And then people who live in a nursing home or long-term care facility, of course, many of those people are elderly. And then, of course, people of all ages can be in a higher risk of severe illness group if they have underlying medical conditions, especially if they're not very well controlled. So I've listed several below here: chronic lung conditions, asthma, diabetes, serious heart conditions. People that have these conditions should they become infected, have a higher likelihood of developing severe illness. Clinical care and treatment. Most important is we need our healthcare workers to have personal protective equipment. That's mask and eye covering, and a mask over the nose and the mouth, and eye covering, and gowns and gloves. And so that's just part of the clinical care and treatment paradigm. And of course, many of us have been hearing in the news that it's in short supply, sadly, for many of our healthcare workers. However, now back to treatment. Treatment is given, it's similar to other viral pneumonias. However, it's primarily supportive care and oxygen is needed. Corticosteroids don't help, they're not recommended. There are no drugs to treat this new virus with. And so convalescent sera is just starting to be tested as we have more people that have recovered. And if they've recovered long enough, going out several weeks, and they meet other criteria, which are significant, then they're eligible to give blood and to have their serum and plasma and the antibodies collected and then processed so that it can be administered to someone who's severely ill. So that is being tested right now to see how well that works. And there aren't all that many people, given how new this is, there aren't all that many people who actually meet the criteria, but there are a growing number. So this will be tried more in the months to come. There is anecdotally, but under trials, so hopefully we'll have hard data, a drug called remdesivir, which is a drug that inhibits viral replication, could be useful, and it is being used in treatment as a part of clinical trials. The Chinese approved a drug called favipiravir as investigational therapy, but to my understanding, it's not being used in the United States at this point. There are over 100 clinical trials underway to test all kinds of compounds against SARS-CoV-2, and including hydroxychloroquine and azithromycin, which has received such notice the last couple of days. And there are more than 11 vaccine candidates that are in development, and one is actually already in a phase 1 trial. Now, trials, especially for vaccines, there are 3 phases. There's the first phase where it goes into a very small number of people just to see what their antibody response is and if they have any untoward side effects. Phases 2 and 3 are putting the vaccine into larger numbers of people to really discern, again, even better how safe and effective the vaccine is. Severe outcomes. All right, so these are data that speak to who's experiencing severe health outcomes if infected with COVID-19. So in a data that was reported by CDC of 4,226 laboratory confirmed COVID-19 cases, 31% of cases and 45% of hospitalizations, 53% of intensive care unit admissions, and 80% of deaths were in persons over 6 or equal to 65 years of age. The highest percentage was of severe outcomes were in people over 85 years. Graphically, this is, you can see by age group along the x-axis and number of hospitalizations on the y-axis. Again, you can get to see, again, where hospitalizations and ICU admissions and deaths are occurring. Please note they're across all age groups. So although we talk a lot about groups, elderly people being at higher risk, that severe outcomes, hospitalizations, and deaths can occur in all age groups. I have better data, just today, actually, better data was reported out by CDC. And here, this was data, again, if you look at the percent of COVID-19 patients by underlying health conditions and hospitalization status, you can see that this was a study looking at 7,162 people with underlying conditions. These are all in COVID-infected people. And 38% of those 7,000 had at least one, but more than, could be at least or more than one underlying health condition, which some of which individually I've listed below. But you can see that looking at those that are hospitalized and those that are put into ICU, intensive care units versus not hospitalized, you can see the huge percentage difference. So these underlying health conditions really do put people at much greater risk of severe health outcomes. In children, and this just came out today, there were again, looking at 291 children, those are people under 18 years of age, but comparing them and with their signs and symptoms with adults, people aged 18 to 64 years, you can see the percentage of the children compared to the percentage of adults. You can see that children really show fewer, the proportion is much less in children showing this sign or symptom compared to adult. And it generally follows all the way through. And again, afterwards, you will see this. I'll let you look then at some of the details. But basically, in general, children symptom-wise do better than adults. That's, however, they're not off the hook entirely in terms of severe illness. And so here, this is a graph of, again, children's, I guess the higher age category here was 17, but infants, toddlers, and then other children at other ages. You can see a lot of them are not hospitalized, but this dark blue means they were hospitalized, and then the light blue means that they found themselves in an intensive care unit. And there actually have been some deaths in infants and in children under 18 at this point. Not a lot, but it can occur. All right, I'm going to skip over some of this, but again, you will see who should seek medical evaluation. The big message here that if anybody in this call who's not yet infected, but you become ill with a fever and a cough or shortness of breath, it's important that you not just head to the emergency room, that you stay home and basically get in touch with your health provider. And you ask them for advice, and he or she will ask, about your symptoms and clinical signs, how long you've been sick, what you're doing, and you get in touch with them, and then they will give you directions as to how to proceed. If you don't have a healthcare provider, you can call a public health clinic, and the website is given here. And then again, if you develop these signs and symptoms, you want to keep yourself separated from other people and animals in your house, and cover your coughs and sneezes and wash your hands. And then there's also a hotline you can call. And we actually now have several call centers and different telephone numbers to call with different questions. But if you think you were exposed to a confirmed case of COVID-19 and you have questions about it, you can talk about it with your healthcare provider, or you can call this call center to get information. Laboratory tests, we've heard a lot about those. Laboratory tests are important for clinical diagnosis and treatment, and but also for disease surveillance, which I was mentioning. And sometimes you can use the same test to do both, but sometimes you use different types of tests for different purposes. Most of the tests that are being used are based off of a specimen that's a swab, a specimen from your nasal and oropharyngeal surfaces. And there's a real-time PCR, polymerase chain reaction, which detects viral nucleic acids. So this is detecting the virus. And it's used to, if you get a positive, there's an active infection, but it takes often in this environment, in today's world, sometimes days to get a report back. There's more recently a faster acting and express SARS-CoV-2 test that also detects viral nucleic acid. It's for use at point of care, and results are reported back in less than 1 hour. There's a rapid serologic antibody test that has just been approved by FDA. Now, serology and the detection of antibodies occurs later. than when you might just first be infected. IgM is the first class of antibodies that gets developed immediately, and then farther down the road, your body detects other antibodies or develops other antibodies called IgG. The results of this rapid serologic antibody test also being used by health providers and at point of care, you can get that back in 15 to 20 minutes. And then there's at-home collection and test kits under development, but still have yet to get FDA approval. There's lots of issues with those in terms of accuracy and concerns over potential fraud. So those are still under development. The tests are used, and again, this antigen detection, PCR, is used to detect new cases of disease in a defined population. And the antibody tests are basically used to detect new and pre-existing. And there's a kind of an interesting graphic here to try to show that in the population, you'll have new and old cases of illness, but the PCR will affect these new cases coming in. The antibody test will give you readings for prevalence in the population. So that's kind of a quick explanation there. Now, who is getting tested? Those are great, all those tests, but their availability is increasing. It's getting better, but it's not across the board freely. Everybody can get a test who wants one. So there are limitations that remain in a growing capacity, but nonetheless still limited to obtain specimens and process these lab results. And so in Washington State and in King County, there's a priority that's been set for testing with hospitalized patients and healthcare workers and people working in public safety occupations or special groups that could be very prone to super spreader people living and or working in these long-term care facilities or corrections places or homeless shelters. They get priority. Not everybody who feels ill could be tested at this point, especially with our limitations in testing. If you have mild illness, a result will not impact the treatment. Of course, we need that information to know how much infection is in a population. But the bottom line is that if any of us become infected and develop symptoms, we need to talk with our healthcare provider, and they can discern whether you should be tested or not and make that recommendation. You can read the guidance on this at this website. So strategies for disease prevention and control. Generally, in a brand new pandemic illness, right when the cases are very few, right at the beginning, there's a strategy of containment that we want to follow. And this is where, hopefully, and this is where having a test earlier would have been very helpful, is to confirm people that actually are infected and then to isolate them and then to find out who they've been in touch with and to do contact tracing and then find out if they're ill or not and put them either in isolation or quarantine. And so you try to contain it so it's not growing, it's not spreading rapidly through a population. You're kind of keeping the parameters around it and hopefully treating those people so that eventually it would die out rather than spread. However, if transmission, and especially when community spread starts to occur, you can get transmission then that outpaces what you're able to do here. And so then it morphs over into kind of both, but more emphasis put then on mitigation to deploy in influenza. And this is a slide used for other infections where you might have antivirals and vaccines. You use those very broadly. We don't have that with COVID-19, but we can start deploying non-pharmaceutical interventions back here and over here. And I'll be talking about those coming up here. Isolation and quarantine. Isolation is a term used to separate people who are ill from other people and to restrict their movement to avoid spread of the disease, where quarantine is a term that's used to restrict movement of people who are well, who don't have symptoms, but they have been exposed, potentially exposed. So they're waiting for some period of time, usually that incubation period, to see if they do become ill. And if they do, at that point, they would be isolated. So where do we find ourselves here this evening? We've got a novel virus never seen on the planet before that spreads easily person to person, that is capable of causing severe illness in a significant proportion of the population. We have the world's population, about just short on 8 billion people. Nobody up until it started to grow in number had immunity. 8 billion people totally susceptible to this virus. And this virus likes to go person to person. There was limited testing in the US. This is special to us. Other countries were able to do better. And there are no drugs that have been proven effective for treatment. There are several on trial, but none of them have yet been conclusively shown to be absolutely effective. And we don't have a vaccine for preventing infection. That's under development. So then what do? Well, we don't give up. We turn to non-pharmaceutical interventions as a main tool at the moment to confront this pandemic. And that's to physically separate people so that the infected people, as they may cough or sneeze or dispense those droplets do not make it to somebody else. And so those 2 to 3 people that on average, every infected person could infect, they don't get infected, right? So that's what happens with social distancing and physically distancing. And that coupled with everybody washing their hands and not touching their face and cleaning, cleaning's another thing too, cleaning surfaces. This is what we're doing. There's a whole list of non-pharmaceutical interventions. And again, these are ones shown here that those are ones that we can do ourselves personally at home. And earlier in our experience here, there was voluntary isolation of ill people and voluntary quarantine of contacts. And then efforts made to have people, when they became ill, to stay home and not go to work. We've graduated, though, because of how rapidly this transmission has occurred, and trying to get ahead of the virus, and these are non-pharmaceutical interventions that often governments will take to cause involuntary isolation or quarantine or cancellation of major public private gatherings, closure of schools, preventing non-emergency travel outside of home, etc. The goal is to reduce the number of cases and therefore the number resulting in severe illness, and therefore putting less stress on our hospital care system, minimizing social and economic impacts, and essentially buying time until drugs can be identified that are effective for treatment and a vaccine is available for us to get to prevent infection, and to stay within the capacity of our healthcare system. So I'm going to talk a little bit about mathematical modeling here very briefly, because in the absence of actual experience and data, we do, and I know we've got a lot of people in the audience here who could very well be modelers, that mathematically you can take, you know, what we know about growth curves and doubling and rate of infection and proportion of illness, death, hospitalizations, looking at strategic points for disease control interventions and economic benefits and costs, that then we can actually use those observations to predict what may happen under different scenarios. It can also help to identify missing factors. For example, once some of the models that now are being used were starting to be used, they saw that originally it was thought that only symptomatic people could transmit the virus, but with the modeling results, they saw that no, there has to be something else going on. So they began to question whether in fact there might be asymptomatic transmission. So you've seen this graph potentially. The idea here is with these non-pharmaceutical interventions, we're going to try to keep what we observe in terms of cases happening within the construct of our health system capacity, so that those who become severely ill and need a hospital bed and potentially need a ventilator to breathe and a well-functioning healthcare worker to run the ventilator, that we can stay within this construct, and that New York City, for example, and New York State, they're in big trouble right now. They actually are kind of above what their healthcare system can provide. I think here we've done fairly well, and we're not in the same predicament as New York is, very luckily. Another model that was done, and I've given the reference for where this model comes from, and this, I believe, was shown to Governor Inslee, which was, okay, according to the model, if we don't do anything regionally, by early April, we could see 15,000 cases. But if with non-pharmaceutical interventions, if we can reduce contact reduction by 25, 50, or 75, this is what we would see. And so we're about right about here. So we've done pretty well. We're not at 100% effective contact reduction, but nonetheless, I think the numbers are showing that it's starting to work. I'm gonna very quickly now, a public health response. This is what your public health departments are doing. They're conducting disease surveillance and investigation. They're developing guidance on those non-pharmaceutical interventions, on how best to implement them. They are implementing and working with different community groups to help them implement the interventions that are laid out in the guidance, coordinating services for cases under isolation and quarantine, disseminating and communicating important information, and engaging with communities who are who might be most impacted, including the most vulnerable groups. There's all kinds of guidance online. In the presentation later, I know I'm going to quit here, and we're just at about an hour, 55 minutes. So, but a lot of the guidance here on these are available online. The King County Health Department, so website, Washington State has a special COVID-19 website, so does CDC. And so the different guidances and details can all be looked up, and they're basically, they're there for individuals, for schools, childcare, businesses, different community organizations, government services, vulnerable populations, and then special guidance on cleaning and disinfection. This is King County's website, and when you go to the King County COVID-19 website, and this is just one page. You can, down below, there's all kinds of different, very easily navigable different sections you can go to. This is the website for the state health department. And again, they've got an interactive dashboard that is updated regularly, so you can see testing results and where the cases are occurring. CDC has a website with all kinds of information. This is some of the guidance on cleaning and disinfection. Again, it's very detailed at that at those websites. So I'm, again, in lieu of time, I'm going to go quickly here. There's also, what can we do as individuals? I've listed that, and our community mitigations branch has listed several of these. These are all things that we can do individually. However, that said, the governor and our health officials were seeing that even with some of what we were hoping people would do individually, there was continued spread and an ever increasing number of reported cases. So beginning in March 13th, that was when the first school closures were put into effect till April 27th. Of course, that's now been extended to, as of today, to the end of the school year. And closure of bars, restaurants, it was happening kind of, ever ratcheting up what was happening until on March 23rd, Governor Inslee declared the Stay Home, Stay Healthy initiative and closure of all non-essential businesses. So, and that is in effect now till May 4th. I've already commented a couple of times on disease surveillance. It's so important that there's a number of different, in addition to testing, there's the county and CDC in general, the state, all of the health departments are looking at in syndromic surveillance, keeping track of people who are hospitalized with COVID-19-like illness, not necessarily laboratory confirmed, but who have a special constellation of symptoms and pneumonias. And there's also the Seattle Coronavirus Assessment Network. In our area, we've got fantastic researchers, and I'll just mention this too. I meant to mention it with the drugs and the vaccines. We've got some of the nation's best researchers looking into these things locally and with national and international import. But this was one study that the University of Washington was doing around influenza, and once COVID-19 hit, they began to test specimens for COVID-19 infection. Modeling, again, this is what modeling will do. You can see how are we doing, and this isn't good news for the United States. This is where we are on this graph. Are we flattening our curve or not? It's kind of hard to tell right now. But there are some hopeful glimmering signs that maybe we are in some of the harder hit areas, but you can see other countries actually seem to have fared better. This is an example of our weekly of hospitalization, inpatient hospitalizations for COVID-like illness that I was mentioning. And again, this is an example of what surveillance will do, but I want everybody to be careful here. The interpretation is not, oh, look at how much this has dropped. We're still waiting for reported cases to actually come in. So we're still, what we can interpret is still back here. So we're still waiting to see. And again, other epi curves. This is a recent from modeling. Again, looking to see what's happening with the R0 value, and are we actually driving it from 2 to 3, which would be without any intervention, down to somewhere around 1 or below. And so again, this is looking like maybe we might be doing having an impact, but this of course is when the stay home, stay healthy policy went into effect. So time will tell. Okay, conclusions. This is a slide that talks about what we still don't know and what we're still learning. to put it in the more positive framework, because we are. It's like drinking out of a garden hose. We are learning so fast, so much, so it's really remarkable. But nonetheless, here's what we still don't have. We don't have an exact measure yet of what the impact on social distancing is having on new cases. We have the models, and we are starting with our surveillance to follow those cases. So with time, we'll be able to know what that impact is. We don't know the prevalence of infection in the community in different populations at risk. And this is largely a result of unfortunately still lack of testing that would allow us to be able to discern this. We don't know the complete range and frequency of clinical disease signs and symptoms. We're still learning. So had I made this presentation a month ago, it might have been just the fever, the cough, and shortness of breath. But now we have all those atypical signs that we're starting to see. But so we're learning with time. The immune response. So for those, and we have 3 of our friends and colleagues with us tonight who are going to talk about their experience. They had some kind of an immune response. But what it is, what it means, are they now immune to reinfection? Will they continue to have this immunity with time? We just don't know that right now, and time will tell. The infectious dose. Does it take one viral particle to become infected, or do you have to have enough viral particles to actually become sick? We don't know that. The amount of transmission via surfaces, I mentioned. Drugs, we're still in the vaccine. We're still and giving a lot of thought to what are appropriate criteria for not only closing, but, well, that's been worked out, but now what about opening everything back up? And so that we're still learning as we go. And of course, we still over time will want to and will need, it's not emergency right now, but going forward, we really will need to see where the first couple of cases came from, what the reservoir of the virus is, and how those first people became infected, and much more. What we do know is research findings are coming daily, and that we do know that non-pharmaceutical interventions do work. We don't know exactly the amount, quantify the amount, but we know that by separating people and washing our hands and cleaning surfaces, we can slow and reduce the transmission of this virus, and that will lead to fewer cases and fewer seriously ill people. We know that we have to plan better for PPE, personal protective equipment, for our healthcare workers. And that they are running up against shortages is just terrible. We are learning lessons from previous pandemics. We didn't get a chance, and we had a slide, but not can put it in the ones that are posted. But we're learning from what we learned in 1918 with the influenza pandemic. We're learning from what happens with seasonal influenza, from some of the other 2009 H1N1 influenza and the H5N1 avian influenza scare that happened in 2003, SARS, and then we're learning from COVID-19 epidemics in other countries. And absolutely critical in all of this is disease surveillance to help guide us in terms of how we're doing and what is working. How to stay informed. You can look all of this up on the posted slides. There's websites given to our county, King County, Seattle King County Public Health, the Department of State, Health Department, CDC. There are health sites. This is a really interesting one with the Institute for Health Metrics and Evaluation at UW. They actually have this interactive modeling that's fun. Well, if we weren't living through the terror of this, I'll take that back. It's interesting. And but you can actually put in different parameters and see what would happen. I'm going to stop. We're all in this together. Everybody's sacrifice and contributions to maintain social distancing are needed and greatly appreciated. We have to stay strong. We have to keep going. And then finally, you will see there are these different call center numbers. There's one for medical questions and non-medical and business related, general questions. And so lots of resources out there for you. And with that, I will stop. And you can see I wanted to stop with something positive in that I think some of you may have heard in the Seattle area and King County, especially for the children, to put these teddy bears, since we can't really get together like we used to put these teddy bears in our windows. So just as a small token to really underscore that we are, that we're physically separated, but not socially. So I will stop there and can take questions.
All right. Hi, this is Ken. Thank you very much, Marguerite. I found that absolutely fascinating. People have been entering questions. But before we get into the questions, I think I'd like to turn it over to the survivors here and have them talk a little bit. And then we'll get into some questions. So I'm going to unmute Paul and Tana. I think you're both live now. And if you just want to talk a little bit about what it's like, or if you'd like, I can shoot you some questions. Paul, you had a pretty serious case here. You want to talk about it a little bit? What it was like, how you got it, possibly?
Sure. I didn't know that I had it. It was really early on. I was at Virginia Mason for an elective surgery on March 5th. And when the doctor looked at the CT scan, that was a routine test before my surgery, which was a cardio ablation surgery, he discovered that I had pneumonia. And he canceled the surgery, sent me to the ER, and they examined me for the pneumonia, but also gave me a COVID-19 test. Then they sent me to a negative pressure room and kept me overnight for 2 nights to keep an eye on me and see how I was doing. And this is kind of the short version, but you said I had a pretty serious case. I describe it more after all the reading that I've done about really serious cases as a moderate or moderately serious case. It wasn't like the light cases that most people get, but I had a fever, a bit over the 100.4 that was described as a kind of a threshold. I had a cough. I had slight shortness of breath, and I was in a bit of denial about that. I thought it was just a cold that morphed into a bad cold, that I wanted to go away so I could have my surgery. And I think I was probably around the 100th or 150th positive test in Washington State. If you look at some of those graphs, March 5th, there's hardly a blip on the graphs. I was sent home on March 7th and told that the medical people at Virginia Mason didn't know when I'd get the test results back. One day or one part of a day would be, they would say one day, and the next day they would say maybe 3 or 4 days. And the next day they would say, have no idea. But it came back positive on the 10th, and I was already at home, kind of plateaued with still not feeling that well, and told that I wasn't getting any worse. So I was waiting for the fever to break and for some of the other symptoms to go away. How did I get it? I think there's a picture of my wife here somewhere on this screen. Susan had also not been feeling that well. And her symptoms.
I've unmuted you, Susan, although, oops, I might have to mute you again. Sorry.
Her symptoms probably peaked around the same time that mine did, but they weren't as bad and they didn't last as long. So when I was discharged from the hospital, she took care of me. And it's a bit of a puzzle to try to analyze what might have happened, but either she took it home and gave it to me in February, probably around February 25th or 26th, because that's about the time that I started feeling like I was getting a cold. Or I took it home, held on to it for a while without spreading it, and then gave it to her. And then we both had it for an overlapping period, but mine just got worse and stayed bad until it broke in one day when the temperature went down from mid 100s to my normal, which is slightly below 98.6. Susan,
sorry, Sue
go ahead.
Never tested, so we will never know about her.
No, we'll never know about her. I was seen by the infectious doctors at Virginia Mason.
Someone has to.
So I was seen by doctors who were just starting to get immersed in this pandemic at their hospital, and they tested me right away. And they told Susan that because her symptoms weren't nearly as bad, that she didn't need to get tested. And I think that advice has borne itself out because.
Well, also, there weren't enough tests.
Yeah, and because there were very few tests at that time. So it just really occurred to me just yesterday talking to a friend that she must have had it because she took care of me through my worst days before I went to the hospital and for the 4 or 5 days after I came home. And I wasn't staying in a separate room. We did switch to 2 water glasses in the bathroom and a few other precautions, but not all the really major precautions that people with a serious disease are following. I could get up a bit unhappily and my energy level really dropped. I didn't want to do anything except sit and sleep. And that's actually been the hardest thing to get back. I'm still getting tired early. I am walking now. I'm walking up to 2 miles a day, very slowly and very carefully and gingerly. So not with a lot of pep, but I'm getting out and going outside for walks.
Is it the assumption that you're no longer shedding virus at this point?
Yeah, the doctors gave us both very individual and separate rules about the quarantine. I could be considered finished with the virus 72 hours after the last day of a temperature. And that was a particular date. We were monitoring that. Susan had to wait for 14 days after the last day that I had a temperature, or after I think that was right, yeah. Because it wasn't conclusive and it wasn't that comfortable to say that she was better by then, even though during all that period, she appeared to be much healthier than I was. So after my 72 hours passed, I was still very lethargic and not wanting to go anywhere. After a few more days, we devised a strategy for going out shopping. She had more energy, so she drove to the co-op and stayed in the car in the parking garage, and I went inside and shopped. So she stayed isolated, and I took advantage of the fact that I didn't need to be. But we still mostly are staying home by ourselves and following all the protocol when we do go out of staying 6 feet away, even though it's pretty sure that we're not carrying anything. And the common wisdom is that we probably are immune from getting it again, at least in its current version. My understanding is that the coronaviruses of the same family, that's the case with all of those viruses that the speaker mentioned, but there's no specific proof about COVID-19 that says, no, you won't get it again. There's not enough data. And one other thing I'll add, and then if you have questions, since I was an early victim and an early survivor, the speaker did mention the studies that are being done, and I'm participating in 3 studies for my plasma and antibody analysis, because I'm far enough away from having had the disease that they're taking me and taking the blood, or probably next week I'll give plasma that she was referring to that'll be used for patient care as well as for research.
Thanks, Paul. Tana, can you talk a little bit about what happened with you, how you have it, how you doing?
Well, I'm doing very well right now. I believe I got the disease on maybe the 25th of February. So again, I got it early, similar to what Paul did. I believe I got it at my chorus, simply because the only other people I know who have it are all from my chorus. It hit our chorus pretty hard. 5 of the women became sick. 3 were hospitalized. 1 was put on a ventilator and actually eventually passed away. So we lost one of our members, and that was really sad. It also spread then to a couple of husbands and sisters and a brother-in-law. So maybe 10, 11 people were infected from whatever came to our chorus. So that's interesting. Let's see, my symptoms were, the first thing I had was like a dry cough. And I decided then that I wouldn't go out that weekend, because no one wants to hear people coughing when they're talking about COVID-19 all the time. I was also very tired. I slept for about 3 days. I called my doctor maybe 4 or 5 days after I got the disease, and she thought that I was maybe just had the flu and I should just stay at home and sort of, you know, just not go anywhere. And I did sleep for maybe 3 days. I just didn't get up. I mean, maybe for a few hours. Not hungry at all. Nothing tasted good. You had to really force yourself to eat and drink. Drinking is very important. Then I did still, even though when I stopped sleeping, I think my brain did some very weird things. Maybe my brain was clearing out the virus itself, but I had some very weird nights of strange thoughts and extreme sadness. I'm not usually a very sad person, but I was very sad. And so eventually I called my doctor again. She said I should go to urgent care. So I went to urgent care. I got tested. I went to the polyclinic up by University of Washington, their polyclinic now. I got tested. They thought my lungs were not full. They were okay. So I didn't need to be hospitalized. They didn't know if I had, they thought maybe I had just garden variety pneumonia. And, but they did give me the test, which is really wakes you right up. It's like it goes right down to your heart, I think the test does. And the next day, it was only a day later, I got the results that I did have the COVID-19. So, so then of course I kept staying at home. I really didn't feel well enough to do anything. I was probably felt quite sick for maybe 10 days. And then I just got better. I remember one day just feeling like my lungs were free. I hadn't noticed that they were full or that I couldn't breathe, but one day they were just relaxed. It was like, wow, this is good. And then I've been, you know, other symptoms I felt achy, lots of achy knees, achy back, like having the flu. Let's see, I didn't have a very high temperature. Did have a postnasal drip, which was very annoying. And that was kind of nasty. I thought my skin became thinner. I remember cutting myself on a plastic snap, which usually would not cut me, you know. So I thought maybe that happens to your cells too. They just get a little thin when you're sicker. And anyway, those are just all impressions that I have. So I am also working with the CDC and the Blood Works and University of Washington to do plasma samples with them. So
when you first started getting sick, were you aware of COVID-19 at that point? Where was it in the cycle of things? Did you think, I have it, or?
I got my cough on the 28th. And under normal circumstances, I would have just continued whatever my activities. I was going to 2 big events over the weekend, but there was enough buzz about COVID-19 that I thought, no one wants to hear someone coughing at this time, you know, and I was coughing. So I just decided not to go, to just isolate myself at that time. So, yeah.
Great. Thank you. Are there any other survivors on the call right now? I know one other person might have been. Either wave your hand or put something in chat. Otherwise, I'm going to read some questions that have come in that Marguerite answer those. And I want to thank both of you, Paul and Tana, for that. And that's one of the big questions, you know, if you're feeling a little funny, do I have it or not? And, you know, it's, unless you have the cough or the fever, it's, you know.
Well, yeah, call your doctor is the big thing, and then let them kind of guide you to what you need to do. So yeah.
And don't ignore
and keep asking if there's a problem. Keep calling. If you feel like it's, you know, I have a friend who really thought she had it. She was a pharmacist. She wanted to be tested, and took her. She did stay home, but it took her over a week just to be tested, and that's only because she called every day.
All right. Well, thank you. Okay, so I'm just going to read through some questions. These are kind of the order they came in. Start with one for me. How common is it for diseases to be transmitted while people are asymptomatic? Does this happen very often, or is that a big deal about this particular virus?
No, it can happen, and it's, if you put yourself in the shoes of the virus, it's a really great survival mechanism, because you can be transmitted before anybody finds out that you've infected a host, and then your demise is there. So whether there's asymptomatic spread or not really does impact on which strategies you use for detection and control. And but it does happen with other infections as well.
Okay,
so,
thank you.
yeah.
And I should mention that other people, if you have questions, either wave your hand so I'll see you, or type it into the chat box so I can keep relaying questions. Again, I don't want to turn on, unmute everyone, because I think it'd be just too chaotic. But I am keeping an eye on the video screens and the chat box. So keep going. And if you see me looking around, it's because I'm managing too many windows at once here. So pardon that. Okay. Next question is, so the question came up, which I think you answered, that we don't know what the minimal viral load is for infection yet. At this point, we just don't know how much you need. And, you know, are you going to be, if you take home a bag of groceries, is that, and let's say someone was directly coughing on that bag, you know, what is the chance?
Well, that would be worse,
yet?
Right? If you had an infected person who really was coughing all over the bag right before you touched it, that would be the worst case scenario. But for many of us, you know, you're at the store and, you know, you're buying things and nobody's really coughing or sneezing, and so you just don't know. And that's where these asymptomatic infections, you know, really have been a major wrinkle, because you can have people who aren't coughing or sneezing, and they may be, in the sense, transmitting infection. Now, there was another question in here, you know, how does droplet differ from an aerosol? And an aerosol is, you know, where the viral particles are very, very small, and they can just float in the air and just hang there for some period of time. Measles is a great example. Measles is one of the most contagious infectious diseases, and I think the R0 for measles is close to 3 or 4 or even higher. But they did, in that study that I talked about in terms of looking at the survival of viruses on metal, they actually tried to on different types of surfaces. They actually put the virus into more of an aerosolized form, and found that it actually hung out in the air for about 3 hours. So it is, if you have somebody who's asymptomatic, they could be standing right next to you, and as they're talking, the virus can be coming from their mouth and into the air, and then as it hits your eyes or nose or mouth mucous membranes, then you can become infected that way. But again, how much that happens, like what's happening, how much asymptomatic spread is happening, how much is happening on surfaces, they're still trying to, we really don't know. The majority, there still is agreement that a major way, still the major way for this virus is to go via droplets, person to person, through cough and sneezing.
Okay, so related to that was the question of, should we wash fresh fruit and vegetables with plain water, or should we use soap, or what? This is an issue in my house.
Yeah. Well, and it's a good one. Now, yeah, it's there's not any clear guidance on that. First of all, in terms of food, there really is no indication that people have become infected through eating food. It's not considered foodborne, but certainly the packaging and or I guess, basically the packaging and the bags and whatnot, that's where you'll see people, being very careful and wiping down your groceries, etc. But different surfaces, so the different types of produce, or even virus on fabric, or, there's so many different types of surfaces. But in general, the more porous the surface is, it's believed that the virus would not last very long there compared to less porous surfaces. So it's still, I guess, it's what you're comfortable with. I will say I have not been washing my produce. I have not gone that far, but the different people do. But there's not a lot of data to really guide that.
Okay. I have two questions. I'm not quite sure what they meant. One is, at least from Victor, on the face or nose or somehow inside the mucous membrane. Victor, you want to clarify exactly what you're asking there? And would lack of testing affect CFR? And CFR, someone remind me what that means.
It's a case fatality rate.
Okay, so yes. While we're waiting for Victor to type something in.
Or I can speak.
Yeah,
I was just wondering, the droplets, you keep mentioning about hitting the face, the nose, the nose. Is it the outside of the nose, or must it be the mucous membranes that we're talking about, the eyes, the nose, and mouth? It's like just the outside the lips, it's nothing. It's just if it gets the mucous membranes. Yeah,
and or, you breathe it in. So it's into your nasal passages. And of course, it can also be transmitted through your eyes. So if, if those droplets hit your eye and then you're rubbing your eye and whatever, and even if you're not rubbing your eye, if they touch the mucous membranes of your eye, that's another way that transmission can occur.
Thank you.
All right. And then the lack of testing on the CFR. And I think that's, I'll generalize this lack of testing must affect everything, right? Can you? Well,
so yes, I mean, that will. So, because remember a great question, and as someone who knows their math, so the case fatality rate is measured by, how many infected people you have, and then of those people, how many go on to die. So a lot of the case fatality rate estimates are coming from sick people, that were tested and they're positive, but we don't know how because of lack of testing, we don't know the proportion of the population that's infected and then what proportion of them would die. And of course, the denominator could get very large if you have a lot of asymptomatic people. And so the case fatality rate would drop down, become very, very small. So the denominator and testing will definitely influence the people that are included in your denominator. And so that can very much have an impact on what kind of case fatality rates are observed.
Thank you. A question for me. When you list the people at risk, older people, diabetes, what have you, is that based on this particular virus, or is that based on coronaviruses in general? Or do we have enough information now? Because you did have one slide on this, so maybe you do know the particular pre-existing conditions that are particularly bad for this virus.
Well, older people are at risk of severe illness for many infectious diseases. Right. So many foodborne illnesses, but by and large, almost any infectious disease, older people. And then the difference here that there have been a couple of differences that we've seen in pandemics in the past. For example, with the 1918 influenza pandemic, the major age group that suffered the greatest amount of death was actually people in their 20s and 30s, not the oldest people and not the youngest people. It was people in their prime. And that is because that particular virus caused across the board what they call a cytokine storm, which your immune system goes into hyperdrive and really it's going, trying to eliminate the virus, and it leads to all kinds of it can lead to general system failure. Some of the older patients in the severe illness group with COVID-19, those that generally go on to die, actually do they do experience a cytokine storm. But yeah, so that's a very good question. And yes, unfortunately, I guess it's, you're lucky enough to get to a certain age, but the downside is your immune system doesn't work as well as it did when you were younger. But in some instances, it can be like in what happened in the 1918 influenza pandemic, that can be a blessing. Yeah. So, different different agents and different diseases, some are similar, but there's an awful lot of variability.
Okay, we have a couple of questions about favipiravir, whether it's being used.
Yeah,
why is it not
I saw
being
that.
Used?
So somebody there knows more than what I did. I had seen that, and maybe they can offer some additional. Somebody in Tim, is Tim still on? Tim Robinson, he mentioned that it had been completed in 5 trials in the US a few years ago.
Yeah, if anyone knows more, type something in the chat or wave your hands around, or I think you can even unmute yourself. So I guess we'll have to leave that as an open question for now.
This is Tim.
I heard somebody.
Tim?
Yeah, if you just look at the www.clinicaltrials.gov website and type in that drug, you'll see it went through 5 clinical trials, including all the way up to a phase 3 trial, which it concluded. The trial titles are for, I think the disease it was going after is uncomplicated influenza. It never made it to market in the United States, but it did make it to market in Japan, and under special conditions. I just find it interesting that with that history of 5 clinical trials and all the safety profile we would have collected within the United States, you don't find it at all in a clinical trial right now in the United States for COVID-19. I find that interesting, and yet, as you noted, China, Japan, other countries are looking at that particular antiviral.
Yeah, that is interesting. Yeah, I did a quick Google while we were talking, and there's quite a bit of information on it, but I guess we don't know exactly why it's not being used here yet. Okay, I'm going to run through some more stuff because we are getting late here. So I'm going to have to start skipping around, I think. But if anyone has a question they really want to know, type it in to the chat box, so I'll make sure we get it. Let's see. Okay, I think we addressed that one. There are several questions about the quality of the tests, what the differences are, the tests, which ones are better. My question would be false positives and false negatives. How do they stack up?
Right. Well, to get FDA approval, generally the companies do have to submit data on sensitivity and specificity, and this is a very robust area of epidemiology and public health. So sensitivity is what proportion of truly infected people would be test positive, and then specificity would be what percent of truly negative, non-infected people would you get a negative result. Then probably even more important in a disease control setting, of test positive individuals, what proportion have the disease. The prevalence of infection influences that calculation a great deal. And so the fact that we really don't know the true prevalence in the population really hamstrings coming up with really great estimates of what the last calculation is, what they call predictive value positive. But what they do is they will take, as they're developing these tests, they will take known positives and then run the test and see what proportion of the samples come up positive, so that's sensitivity. And the same, they'll take truly negative samples and run the test and see how many come in. But generally, it might be, it's generally not a huge number in each group. So they'll come up with an estimate of sensitivity and specificity that's high enough that it does get approved. But over time and with large, with greater testing, they'll come up with better estimates. The other wrinkle in all of this, of course, is you can take someone who's newly infected, and if they are tested before there can be a very low viral load that the test may fail to detect the nucleic acid of the virus. And so you can have a negative, and essentially a false negative, not because the test was so bad that, it had a huge amount of virus and it didn't get detected, but the person who was being tested, it was just so early that not enough virus was there to lead to a positive test. So you can have people come up with a negative test that if you were to test them a week or days or a week later, the test would be positive.
So on the topic of question of testing, what's limiting the rapid deployment of rapid testing? Is it just?
Well, I think if we can answer that, we'd all be rich people. I don't know. It's one of the biggest mysteries out there. That still, I think we were just so late to the game that getting these things manufactured and distributed, and then, they require a swab and they require a medium to put the swab into for the DNA to preserve the DNA. And then, there were some issues with even having that supply chain and shortage of swabs. And it's just been one challenge after the other. I did see another question. I'll bring it up now. And Susan too, who's online. I personally been involved with pandemic preparedness planning for at least 20, 25 years, up until the time I resigned from, I stopped working at CDC in 2016. I was very much at the table and in line and writing pandemic preparedness plans, and we were practicing them, and we had issues and working out the national, the pharmaceutical stockpile and all of that. So my own family was having this little discussion, and they were talking about, well, this just took us by surprise, and how come we didn't know? And it's like, no, there were all kinds of people thinking about this and working on this for decades. But what happens is, and I think, 2009 H1N1, after that happened, a lot of interest and whatever, and then after it passes, interest goes away. Legislators with budgets, it's hard for them to put money into things that are not visible. And so they start cutting away at budgets, at people, at practicing, and so then we end up not being as prepared as we might be. I did hear, but it's like all of you on PBS NewsHour, they were interviewing somebody who was with the Obama group right at the end, and they had passed along pandemic preparedness plans. They actually did a tabletop exercise with the incoming Trump administration to make sure that they transferred that knowledge and capability. And of course, we all know that the Trump administration just essentially disregarded all of that. So, yeah.
Yeah, we've mostly avoided politics in this particular call.
Well, it doesn't matter party, but, and actually, Obama, partly why they did the job that they did when they moved was he had been so impressed with what George Bush had set up and had transferred to Obama when he came into the administration. So, so different administrations do handle these things differently.
I want to jump, got about 10 minutes left. I want to jump to a question from Wes. What do you see happening as the stay-at-home orders eased prior to the existence of treatments and vaccines? And then my twist on that is, especially since it's going to be different from every state or even city. So, how good are we going to be at flattening the curves if New York, keeps it down, Washington State does, but Georgia and Florida don't, for instance?
Yeah, well, that's a great question, and we just don't really know. And I think this really is where we're all in it together, and we will just have to see, especially regionally, how much travel there might be between places that that had different levels of mitigation in place. But even here, if there's any transmission going on, what happens when you start to ease things up and people start getting back together again? Mm-hmm. And so that was why on the slide, I mean, there are a lot of smart people right now really trying to think ahead to recovery and what, I think I would predict, I don't know for sure, but I'm pretty certain it won't just be, okay, on May 5th, let's just say that there's the stay home stops on May 4th. For sure, it's not like, okay, May 5th, everybody's back, now we'll be exactly like we were. No, it will be done in stages and very carefully, and again, what criteria are used and how that is phased in will be very important. Surveillance will be, again, public health surveillance. It's probably one of the least sexy topics, but it's one of the most important things that happens in epidemiology and public health. So once we start reversing the things, then surveillance is key to detect cases early and to make sure that we're not seeing an increase in transmission that will repeat itself then.
So there's a question here. Why do some sources report recovered cases for Washington State and the US, but Washington Department of Health and King County do not report recovered cases? Or are they reporting? Maybe we just haven't found them. So why is there inconsistency in reporting covered cases?
On negative, the negative test results?
Well, Ron, you want to speak up on that? You asked the question. I'm unmuting you, Ron.
Yes, recovered cases are not being reported, as far as I can tell, in Washington State, but they're being at least estimated by the Johns Hopkins site for the whole country and for the state.
Yeah.
Where's that coming from?
That's a great question, and I'm not really sure where the Johns Hopkins number is coming from. But obviously, it's hard to know because there are either people who have mild symptoms or asymptomatic people. They wouldn't even be included in the count. Recovered seriously ill people, that is more doable. But again, what data are collected and reported and used, for sure attention is going to be given to those numbers that will have immediate use for discerning how we're doing with the response. You could make an argument, sure, recovered people, if we knew, if there was an estimate there, then that might be that pool of people for plasma and serum. So,
can I just say on that, the CDC that I've been communicating with, they said they would have to wait till 21 days after my last possible symptom before they would test me, because they wanted to make sure that I didn't have the virus. So that means, you know, there's a huge delay in when you get it and when you are, since there are no tests to say
when you're recovered,
you don't have it,
right?
To say when you are recovered, well, you know, it's months down the line.
Yeah, good point.
Then there's a question I think we addressed, which is, will someone who thinks they have it be able to be tested in the future to tell whether they really had it? And it sounds like that's still up in the air, if I understand that.
I think eventually it could get there, but we're not there yet. And tests are we're still having issues with availability of tests and then the materials that are needed to collect the specimens and having the personal protective equipment for the people who are collecting the specimens. So it will be a while, but we may get there.
A question on the use of anti-inflammatories. Azithromycin, which apparently is also an anti-inflammatory. Have people been looking at using those? The question is, why isn't it used more? Or
so azithromycin, right, that's used sometimes, you know, it was raised in the same vein as the hydroxychloroquine. And so yes, it's an antibiotic, but it also does have anti-inflammatory characteristics, and it's because of the anti-inflammatory characteristics, I gather, that it's been used for different conditions. But again, it falls into that camp of not being proven for COVID-19 at all. So,
and in fact, that was going to be my next question. Do you want to address the hydroxychloroquine issue? Is it it's simply not tested, or are the reports coming that it's not working?
So it's been, and I actually, my first years at CDC were in the malaria branch. So I really, it's hard to imagine that all these years later now, chloroquine is back on the scene. But hydroxychloroquine and chloroquine have been approved for use in lupus and rheumatoid arthritis and very specific conditions. It can have very negative, severe side effects. And so it has to be used extremely carefully to avoid doing more harm than good in the treatment, even of the conditions for which it was approved. So what's happening right now is very dangerous in that you have people, and even, you have a PhD economist even who swears, well, I can read scientific articles. He does not know a lot of the medical issues behind these drugs. And so it's being used. It's in a trial. So they're looking, it's being studied to see if it meets the criteria for being effective, because certainly we would like to know. And if it is effective, to actually be able to be very clear on what patients and in what circumstances to use it for. However, a sad consequence of what's happening right now is that people who do have lupus and who have been taking it for years to control their health conditions are now having a hard time finding it. So it's really unfortunate.
I'm going to wrap up with one last question, which is, we are attempting to flatten the curve with some success, but we're a year and a half away from a vaccine. Does this ultimately mean some high percentage of people are going to get it, 50, 60%, whatever it is, and we're just spreading it out to take as long as possible? But we are going to get that. So huge proportion is going to have it before the vaccine's out. Is that accurate?
Yeah, well, we don't know for sure, but very possibly so. And so the idea here, again, is so for that proportion who do develop severe illness, that should they need hospitalization, should they need a ventilator, that those will be available to help see them through. And but some proportion will likely, that won't be enough either, and that would die. So but at least it won't be because of the surge that is overtaking what's happening in New York, for example, where there are, people are in hallways and just thousands of ventilators short on what's needed. And so, yes, it's until a vaccine. And then on vaccines, it's always raised as the panacea for everything, but I don't know, I can't see a lot of people, but if people are fairly young, they will have missed what happened in 1976 when there was another pandemic scare of what there was called the swine flu. Yep. And this was a form of swine influenza that infected some people, and it was very similar to what happened in 1918. So there was a big rush to get a vaccine together, and the president, this was everybody go get your swine flu shot, and a lot of people did. And then once really you started to see hundreds of thousands, if not millions of people who were getting their swine flu shot, all of a sudden you started to see people come down with Guillain-Barré syndrome, which is a paralytic paralysis thing that can happen. And until they put this vaccine into enough people, they didn't see that its number needed to find one. They really saw this very, very serious unintended harm that came from that vaccine. So that actually, after that, was when FDA too really started to really up the ante on what criteria needed to be met before a vaccine would be approved for widespread use. So that's why it's going to take the time, but it's really to protect us all from those unintended harms that could come by rushing things.
Thank you. Thank you all. Marguerite, thank you. Susan Buskin, thank you. You're the one who really helped make this happen. Paul, Tana, thank you all. Thank you, everybody. I will post the slides and the recording on the meetup.com page and on the Facebook COVID-19 Pacific Northwest Interest Group. And if you don't see it anywhere else, you can always email me or contact me however you found us in the first place. Margaret, thanks you very much. I'll be back in touch with you, and
yeah,
I'm going to call it a night. I thought it was fabulous, very interesting, and
well, and we're just so glad that Paul and Tana are well and they're with us, and that's great.
And now we all go home and wash our hands.
But we are home, but now we'll go wash our hands.
All right, thank you very much. Have a good evening, everyone.
Thank
Over
you. Thanks.
and out. Bye now.